So tonight's speaker, we're very privileged to have Dr. Weissman with us. And before the meeting started, he asked me not to go through the formal introduction that I was about to give, but I still want to give some of the high points because he's a very amazing man, very well accomplished in his field. His study started years ago after a medical degree from UCLA. Go Bruins. Sorry, SC fans. Basketball's coming up. So some of we directors were listening to a speech that Dr. Strum gave at St. Joseph's Medical Center. And we got a chance to meet Dr. Weissman, and in a Q&A that followed Dr. Strum's presentation, we were very pleased to learn of the perspective of Dr. Weissman, and we were then very happy that he agreed to come and speak with us. He's a local physician. He's been at it in the prostate cancer world for many, many years. Some of his high points, current medical director of the prostate cancer program at St. Joseph's Hospital in Orange, as I mentioned. Co-director of the prostate brachytherapy program at St. Joseph's. He's been in private urology practice in Orange since 1978. Some great training and ultrasound guided brachytherapy, training through Loma Linda in that respect, laparoscopic surgery background. Other aspects of the urology profession that he's excelled in throughout the years. So, is that short enough of an intro for you? Okay, let me not belabor and get our esteemed speaker up, Dr. Weissman.
Larry, thanks for the nice introduction. One of the reasons why I don't necessarily ask for a significant introduction is because whatever it is I have been is interesting for why you may invite me, but whatever I am tonight is what you'll either take away or not take away. So it's for me to prove that I am somebody worth inviting. So I want to start out, I was told that I'm able to give a plug for our program. We have what I would call a unique community hospital program. The picture you see on the lower part is actually a 3-story cancer center next to a 10-story office building, and the office building will have all our oncologists. The cancer center has our infusion center. It has our radiation therapy. By the way, we have advanced IMRT, equally as good as any of the ones that you've heard about and seen marketed, so we're state-of-the-art. What we also have is Kim Moses, if she's still here. She's right back here, and nobody else has Kim Moses, and so that makes us truly unique. What I mean by that is that the hospital a number of years ago recognized that there was a need for a community cancer center, since most cancer care is actually performed in community hospitals rather than in university hospitals. Something like 70 or 80% of cancer care is given in community hospitals, and we have, as people know, a really good medical staff. So the hospital made a major commitment to build a building, to develop expertise, to have program directors, and to have nurse navigators, and combining that with a compassionate approach. So I think we have a unique service. Other things that we have that are unique is we have continence care. It doesn't make any difference if you have your surgery with us. While we'd like you to have your radiation and your surgery and your chemotherapy with us, you can access our lines of care, whatever appeals or is of value to you, whether it be Kim or whether it be our continence program or whatever it is that we have to offer. It is open to the community. Getting to see what you folks do here is exemplary for me. It shows us some of the things that we can aspire to. So, having said that, let me tell you that I was advised that you didn't need another person to tell you about surgery or radiation or give you a typical lecture. And so if you were hoping for a typical lecture, I hope not to disappoint you. So next slide, please. I'm going to tell you how I came to be here, because I was told at dinner, where did I get the chutzpah to stand up as a surgeon and talk the way I talk? So I want to tell you how I got to where I am. First off, I've always had an interest in logic, and I've always been a big question asker. That's one of my hallmarks. I have asked questions for my whole life. Sometimes it gets you in trouble, but it does stimulate you to look for answers and not to be satisfied with the first answer you get. So I would say that was a major formative influence for me. I've had an interest in learning how to communicate better. I can't tell you I've always been a spectacular communicator, but I've worked at it, studied, read, and practiced on you folks when you've come to see me. And what I've learned is that communication comes from a willingness and some study and paying attention to nonverbal communications. So I think it's very important when you talk to your doctor or I talk to you as a patient that I not only listen to what you're saying, but I watch you. I watch your face. I see how you sit. I actually can learn a lot. So I think communications is really critical because we all say things, but we don't know how we're heard. If I only had ESP, or you had ESP, one or the other of us or both of us, we could have a much cleaner communication. But since we don't, I'm going to use body language as part of my help. So interactions with patients. I would confess to you that when I first started out, I knew more than I know now. Anybody else want to say that? When I came out of residency where you're told you're really smart and of course you're going to go into a community hospital and those are the practitioners, they're not as good as the academicians, of course. How could they be? So I went into practice insecure but knowing everything, and I've learned that I can be secure and not know everything anymore, and I suppose as I get older I'll eventually not know anything, but I still know something. Now, a pivotal point in my life was, two pivotal points in my life. The first pivotal point in my life happened in the mid-90s. I'm a surgeon trained to do surgery, was not trained to do radiation therapy, and I got approached by a radiotherapist who wanted to start doing seed implant. And I said, what for would you want to do that? Surgery's way better. So he showed me the literature. And I said, well, it looks interesting. So we started doing seed implants together, and he was the first radiation therapist in Orange County. I was the first urologist to start doing that. After working with him for several years, I left my working with him, came to St. Joe's, and went to Dr. Young Lee. Some people know Dr. Young Lee because one of the gentlemen mentioned having an implant with him just last week. And together we started the seed program. I had some connections, so we went to see Dr. Gordon Grotto. Has anybody seen Dr. Gordon Grotto along the way? But he's a well-known radiation therapist who does seeds he used to be with the Mayo Clinic, and he subsequently went on his own in Scottsdale. So we went and watched him do it, and we imitated some of his approaches. So we think we do a modern approach, real-time dosimetry. But my exposure to a radiation therapist certainly challenged me to think again about whether the only way in life is through surgery. The next and incredibly pivotal experience was a patient that I had who, I'm going to be bluntly honest with you, I'm going to bare my soul and you can think ill of me or not. I used to take managed care patients. I was part of the St. Joe's IPA, and this gentleman had IPA insurance. I diagnosed prostate cancer. He came to see me the next week with his wife, who's a nurse. We spent about an hour, and I told him everything I knew. And about a week later, they came back, and we spent about another 50 minutes. Now, I was, at the time, the secretary-treasurer of our little urologic IPA, and I was responsible for setting up how we paid each other. And we didn't pay for anything other than seeing the patient the first time, or if you did a major surgery. So everything else was subsumed under those two fees. So no matter how many times a patient would come in to see me, there was no additional pay. So when they came back about a week later, and I realized they wanted to take another hour, I had a dilemma. I had a growth opportunity. I could have either grown or I could have not. So as I was walking to the room to see this patient, I thought, what am I going to do? And I quickly, somehow, luckily, made a decision. I sat down and I said, you know, you can come as many times as you want, ask me as much questions as you want, but we got to make a deal. If you know something that I don't know, you have to promise to teach it to me. That opened up an experience, the richness of which I'll explain, but this patient and I made a deal. We shook on it. We've been friends since. He still sees me. Initially, he came back a week later with 3 thick loose-leaf books with prints that he had made from the web. I read some of those. It was really too much to read it all at one swell time, but he subsequently began emailing me, and what he emailed me was oftentimes Dr. Steve Strum's answers to the P2P posts. And over a period of several years, I got exposed to hundreds, if not thousands, of Strum thoughts. So I actually tell people I got strummed. I tell Dr. Schultz that I got strummed. He understands me because I like Dr. Schultz, and I've been Schultz too, except it's easier to say I've been strummed. So that exposure to Doctors Strum and Schultz converted me from a traditional, and the seeding approach, converted me from a traditional surgeon to someone who saw that the world was a bigger place. And with my interest in asking questions, prostate cancer is a marvelous opportunity for someone like me. As you know, we don't have right answers. I hope there's nobody here that expects somebody to come and talk to you and you're going to believe them and they're going to tell you all the right answers. If you do, you'll probably get disappointed in the future because we really, at this point, do not have right answers. So if we don't have right answers, we have a lot of information, and we have to have a logical structure how to be in the midst of a wealth or a welter of discordant information and still walk. How do you go any place? How do you take care of people that way? And so for somebody like me, this is a perfect type of a condition for me to be involved with because I get to advise folks about things I know. I can be smart and know a lot of things, and I can tell you what the likelihoods of anything I tell you being right or wrong. I confound you when you want me to tell you what to do, unless it's clear. There are a few things we know that are clear, but I get to actually use this wealth of information to share with you, which sounds exactly like what you have told me is what this group is about. So I feel a concordance with the approach you folks have and the way I've developed my approach. So next slide, please. What I'm going to now share with you is how excuse me, you can't clone me. We don't know a way. So whether you like my approach or not, it's not possible for everybody to be exactly the same. We all have different styles. Some of our styles will appeal to you and some won't. Each of you have your own styles. So what I'm going to try to do in the next little piece is to tell you how you might deal with your doctor, because patients oftentimes tell me, especially because I have time to spend talking to you, I'm at a point in life where I get to enjoy what I'm doing. I don't have to be as busy as I once was. That's not going to be possible with every doctor you see, so you have to get some help perhaps from me how to deal with us. I give the same lectures to the drug reps because they sometimes when they start out don't know quite how to make an entree with doctors. So in a certain way, think of yourself like a drug rep trying to get your drug into that office. So in your case, it's you want to get your body attended to in a way that helps you. And some of us are impatient. Some of us communicate with different styles. I'll give you examples of different styles. You come to a doctor's office and you have an ache in your lower abdomen and it goes into your testicle. You could go to many doctors who will say you've got epididymitis. They maybe won't check your urine. Maybe they won't, or they will do an exam. Maybe you're tender. They'll give you some antibiotics. That's what I call summary justice. It's a style. It's not right or wrong exactly, but it's a style, and it's much present. Perhaps some of you have experienced that. The alternative style, my style, may not appeal because I'm going to sit you down and tell you what I know and what I don't know. And the problem with that is you're not going to leave feeling like you've been diagnosed. But I say to you, I don't really know. That's the only right statement I can make. Let's together figure it out if we can, or let's at least acknowledge that we don't know, which again, as I say, it seems to me this fits with what I've been told is the style of this support group. So what you need to do is turn your doctors on to that style. Or if they refuse to play in that approach, and if that's the approach you'd like, and you've done everything you can, unless your insurance keeps you from making changes, look to see if you can find folks who will play. It's a game, a certain type of game. It's a communication game. You say something, they're supposed to say something back. It's a dance. It's like doing the tango. If you want to do the tango and your partner is not tangoing, it's frustrating, isn't it? So how can you turn your doctor on? Well, the way I got turned on is by knowledge. So perhaps you don't have to have the doc go through the confusions I went to for the first 2 visits, but what you might say to folks who aren't playing is, when can I come back when you might have some more time? I know you're busy today. I can tell your office is full, but I have a lot more questions, and I feel the need to have them answered. And that could be a start. And when you come back and you have a chance to ask them quite bluntly, is there any chance, you know, I do a lot of reading, is there any chance you'd be interested in if I left you some of the literature? I attend this Fullerton support group. I get a lot of information. I don't know what's right or wrong. I like your opinion. I value your opinion. You want to build the docs up. You don't want to knock them down. You want to give them a chance to grow. Give us a chance to grow on the job is what I'm saying. Then judge us and decide whether we fit you, and also judge yourself. You have to judge yourself. You have to decide, are you bringing a self to the doctor's office that's going to be difficult to respond to in the doctor's office? Because there are places where you can come where a difficult self can be better worked with, like a support group. We have a support group where we attend to emotional issues. It's not so easy for most doctors to really attend at length to emotional issues. So you have to look in the mirror and see who you're being when you show up at the office. Because if you leave the office frustrated, it may or may not all be on the doctor's shoulder. So next slide, please. So some of the things I recommend, I'm sure you've heard these things before. How many of you have done a Strum PC diary? A few of you have. So I'm convinced that Dr. Strum's approach, or Dr. Schultz's approach, or anyone who wishes to have you as a partner, their approach would be to have you know your story. And the reason for that is twofold. Number one, if you know your story, you'll be able to find places on the web where your story fits that story, and then you can see what are people with the same story experiencing. That's the way you have to access data. If you don't have a clear idea of where you fit in, the data will look strange. You know, if you're a certain stage and the data talks about a different stage, curates with this or whatever, and you don't know where you fit in, then the data won't exactly fit to what you're needing to know. So I recommend you know your story clearly. And to know your story, you need to get feedback from the doctors. So does everybody collect their labs and their x-ray reports? How many people don't? Just a few. Most people seem to collect it. So the reason why that's important is because, and also another thing, depending on where you go, do any of you have the doctors say, no news is good news? Anybody been handled that way? So that's good, because I recommend that you don't allow us to do that to you. And the reason for that is we're human. Our systems are not perfect. So no news is good news is also a way for us to not share bad news with you at the correct moment in time when it might make a difference. So not only get the news, but get copies or reports in some way so that you know what we're knowing. Now, studies are an important deficit in prostate cancer. As most of you know, the number of studies, good studies that have been done for prostate cancer are relatively small. We have a difficult time recruiting patients for it. One of the reasons, we were talking about it during dinner, but one of the reasons why we have a difficult time is some studies have a placebo arm. And everybody wants to be treated with something, and so people are reluctant to take a study where they may not get a choice that they would have liked if they weren't involved with the study. But placebo arms are of importance if we're ever going to know anything. Now, women who have had breast cancer have taken part in studies like this for years. So actually the knowledge of how to take care of breast cancer has been judged to be at least 10 years ahead of us. Men have not insisted on the same sort of studies. Men haven't advocated for it. Men have not spoken up for it. Now, groups like this have power that individual men, of course, don't. But women, of course, have organized in ways to get more power. So advocating for yourself is a critical part of getting more information from the future. I know that everybody is hoping that the future will bring things we don't yet have, such as better chemotherapy, better diagnostics. Are there any people here who are early in their prostate cancer care? I know there's some. And so the folks that are early in the prostate cancer care are just beginning down a path that a lot of the rest of you have gone on for a long time, and maybe not know as much, but certainly everybody has this wish, this prayer, that some of this research will bear fruit, and that in the future you'll be able to have therapies that are not yet available, and diagnostic capabilities that are not yet available. And the only way you're going to get that is by advocating and participating and demanding, basically demanding. You have to demand through political action, or whatever it takes. Now, I'm going relatively rapidly, but as soon as I finish with the comments that I'm making, I hope that you guys will besiege me with questions. Otherwise, you won't get the advantage of my visiting with you. So let's go to the next slide. I said this was going to be a different talk. I don't know if people have you had people come from insurance companies to teach you how to work with them? A long time ago. Anybody think working with insurance companies easy? And raise your hand if you think it's easy. I'm not going to raise my hand either. I think working with insurance companies is, let's see, I'm trying to think of a polite thing I could say. Since I can't, probably difficult. Thank you. Thanks, Murray. So how do you work with your insurance companies? Well, I'll give you some ideas if you're willing to do it. Number one, document, keep a logbook. I suspect that a lot of the care that you folks have is expensive. It's well worth your while to know your rights, to treat this like any other investment. It's an investment in your health. It's also an investment in your pocketbook. There's lots of folks that are having trouble getting their insurance to take care of what you would think would be ordinary standard elements of your care. So document things, date and time. If you're particularly having difficulty with insurance companies, send letters. A good legal approach is to send a letter to the person who actually you spoke to. Get their name, get their phone number, get their address, and send them a letter. This is only if you really are having a problem. If it's a minor thing, you may not have to do this. But send them a letter saying this is to document the conversation we had on such and such a day in which you said the following. If I don't hear back from you, I'm going to assume that you're going to take care of this. Another thing to do if you really are in trouble and not getting anywhere is send the letters registered. One of the things I found out from my office manager, whose husband was a postal worker, is that there's a presumption when you send something registered, or even by mail, that if it hasn't returned to you, that it had to have been delivered. So oftentimes insurance companies say, we never got it. Well, one of the better ways of making sure they can't say that is to send it registered. I will tell you, even if I send it registered or my office manager sends it registered, they still say the same thing. They still say the same thing when I do billing by computer through an intermediary where I may send 3 line items for a patient for 1-day service, and they'll pay on 2 line items, and they'll say, we never got it, and they couldn't possibly not have gotten it. So you've got to figure that they're difficult and document. And finally, if you've done everything you can and you can't get through, I recommend, if you can do it, be Machiavellian. Does everybody know what Machiavellian is? For those who don't, it means to be cold-blooded, to do what it takes to get the person on the other side to do what it is you want, and to get them to do it thinking it was their idea. So there are a variety of techniques. You can work on it. But one of the things you can do is you can use a little bit of the legal, not threat. You don't want it to be a threat. You just want it to be something like, before I get to that, if you're having trouble with the person you first talk on the phone to, say, I really appreciate all your help. I detect that you're not at a level in the organization where you can really take care of this. Can I speak to a supervisor? Now, it turns out with some insurance companies, they say we don't have any supervisors. I actually quit companies that don't say that. And there are. You can't get anybody to take responsibility. But all the big ones have supervisors. So insist on speaking to a supervisor. You'll have to tell your story again. Document what you said and do what I said about sending it. This is if you're having big problems. And if you finally don't get through, say to them, look, I don't know if you're having a problem. Is your organization keeping you from helping me, but you don't really want me to have to get an attorney to deal with you, because in the long run, hey, I've got insurance, I read it, you're going to pay eventually, I know it. There's no way you're going to get out of paying, so why don't we take care of it before I get an attorney? Now, the only danger in that, of course, is they may still be obstreperous, and you may actually have to get an attorney. But if there's enough money involved, it may pay off. Actually, the problem with the insurance companies is getting bad enough that they may actually shoot the golden calf and lead to socialized medicine. I don't know if you folks want it. Most of us don't want it. I know the insurance companies, I don't believe they want it, because it'll be a government run. It won't be the insurance companies making the money. It may be beneficial in some ways. As you may know from reading in the paper, approximately 30 to 35% of the insurance dollar is currently used in all the levels of administration. That's money that you pay, somebody pays, that goes for things other than your care. Medicare is roughly 5%, so it's a dramatic difference. But Medicare has certain other arbitrary qualities that may actually not be in our best interest, such as the government, the legislature, saying we have a deficit, so we need to cut pay to doctors and to hospitals. We may have to change the drugs that you can have. So they're capable of making decisions not based on health care, but strictly based on their budget decisions. I don't know if that's in the best interest, but the eventuality may come that if the insurance companies don't change, that may come to be. Now, I'm going to change focus and go on to the next slide. I'm actually going to talk a little bit about medicine rather than all about myself or about insurance companies. I have a vision, not my creation, but I have a vision about where prostate cancer care has to go. And this vision looks like answers to problems we have now. So what are the problems we have now? Number one, we're not terribly good at deciding who really has an important cancer. We use PSA as our test. And as probably most of you know, PSA is the best cancer diagnostic test that we have. If breast cancer, colon cancer, bladder cancer, many other cancers had a test as good as a PSA, they'd all be happy. But it's not a terribly good test. The reason it's not a terribly good test is that PSA is not cancer specific. So the evaluation of PSA is very complex. We have to look at the changes over time, a variety of ways of slicing and dicing the data. What we need is better testing. So raise your hand if you've heard about EPCA2. Have you heard about PCA3? All right, so you've had speakers come to talk to you. The PCA3 is available. It ups the ante a little bit. It looks to be an additional benefit on top of the PSA. The EPCA2, of course, is the test that has the greatest hope for the future. It's not FDA approved yet, but that test may actually, in fact, pick better who to biopsy. Now, biopsying people is a way to find cancer. As some of you know, many of you know, we're now doing better and better biopsies. We're using local, we're taking more and more cores, 12 cores, 18 cores, or more cores can be done in the office without being a terrible experience for most people. So we're dipping our foot into this repository of huge numbers of prostate cancer. So we're finding a lot of prostate cancer, but what we don't know is who has an important cancer and who has an unimportant cancer. So we need tests to do that. So there are genomics and proteomics. These are techniques for looking at gene structures or looking at substances in the blood that on study coordinate or correlate with important cancers. We don't yet have that, but that's a look at how to pick who has an important cancer. Now let's say we have an idea that you have an important cancer. Now we need to do a biopsy. How many of you have been to Dr. Duke Bond, by the way? So a fair number of you have. So Dr. Duke Bond is one of the world leaders in the use of what I would call high-definition ultrasound with color flow. It has benefit. What most of us use in our offices is several generations less valuable. However, what we're using in our offices shouldn't be thought of as inferior or bad. The reason being that what we have now is we have protocols that we follow. As secondary to statistical analysis, we've been told how many pieces to take and from where. And we can do that with our standard ultrasound. But I don't think that's going to be adequate in the future, because the future is going to ask more penetrating questions. Like, okay, so you can diagnose my cancer, but where exactly in the prostate is it? With the techniques that most of us do, we can tell you approximately within a centimeter, centimeter and a half, a relative location, a zone. We basically base mid or apex, medial or lateral to some degree, but we really can't tell you with precision. So the question's been asked, why do we have to know precision? Because right now, if you have cancer, you have it out, you have radiation to the whole prostate, or you have seeding to the whole prostate. So what we're doing is total gland therapy. So one of the things that the future may hold in store is if we could do better diagnostics and more refined biopsies, maybe we could find some of the folks in this pool of less aggressive, less involved cancers. Maybe we could save some folks from the quality of life decrement that comes from whole organ therapy. So as I don't know, have any of you actually had focal therapy yet? Have all of you heard of focal therapy? Because you've heard Dr. Bond talk. So focal therapy is a burgeoning area. It isn't what I would say ready for prime time, but there seems to be a need for focal therapy based on a lot of interesting information. So to ever get to that, we have to have better tests to find patients with cancer. When we find a cancer, we have to have better ways of picking out where it is. Once we find it, we need tests on the tissue that will tell us by genomics how aggressive that cancer is. And then we need therapies that would actually be suitable for focal therapy. Well, so what are some of the ways of better defining the location of the cancer? There are a couple of things. Dr. Bond is looking at it. We're looking at it. It remains to be seen if the dollars and cents will pen out. I've talked to him. He says the same thing. There's a next level of ultrasound equipment that has an additional level of investigative tool called elastography. Basically, people are looking, what additional information can we get with an ultrasound machine? So high definition with a variety of bells and whistles will be interesting. There's another piece of equipment. How many of you were at the PCRI? Those of you who were at the PCRI, did any of you look at the Eigen display? It may or may not have interested you. It's a technique whereby a piece of equipment is actually connected to the ultrasound machine, and by its ability to register in 3 dimensions movement of an arm, once you register where the prostate is in space, this arm is computer linked so that it can tell exactly where in space, meaning in the prostate, the biopsies are done. So we'll actually pinpoint within 0.5 millimeter or slightly more, depending on the ultrasound equipment, where the biopsies are taken. When we get the results back, we can annotate and say where the cancers are found, so that, for example, if you're a patient that qualifies for an active surveillance program, how many people are on active surveillance? Anybody here? So if you happen to be, if you qualify for an active surveillance program, when you come back in a year to biopsy in the same area to see if it's a cancer more or less, we would actually be able to get back, with such technology, we would be able to get back to the same spot. Now, in addition, this information could be used potentially for focal therapy, because now we know with some precision. Right now, when focal therapy is done, it's usually done with cryotherapy, and it's usually at least 1/2 your prostate, and sometimes with a leg to the other side. So it's actually a subtotal cryotherapy. But if we had the right equipment and the right geographic localization of tumors, perhaps there would be even less destructive technologies that could be used. So in my vision, what we'll be eventually coming to is something that'll be a lot more refined at picking and planning and treating. Now that's as far as the mechanical parts of things. The things that are being worked on and that require you folks to take part are the development of better drugs. As you know, you've had lectures from oncologists, so you know that there's a variety of drugs available, but how many drugs are spectacular? We don't have enough spectacular drugs. But unless you folks take part in studies, we'll never actually be able to have spectacular drugs, because the FDA requires the kind of studies that tell us without question that there's some advantage. And that is also an issue. The FDA has set a bar on how to determine when a drug is valuable that some people believe is too high, and it has kept certain drugs from getting approved. So only with political action, participation, can the future actually come. I'm going to stop with my prepared thoughts, and I'm now open for questions. And we have a mic. If folks have questions on anything that I've talked about or other interesting topics, I'll have you speak into the mic.
Helping others is to the person you're talking to, even if their name is Mary or Jane, always ask them to spell their name. And psychologically, they know that you're writing something down. And if their name is Smith or whatever, spell that also. First of all, you're getting them to do the things you want them to do, so you kind of take some control over the situation. So that works. Also, ask for a case number. A lot of times they'll talk to us, but when you call back and you had Mary, but they can't find it. But if you say it was case number such and such, then again it shows to them, it tells them that you're not fooling around. So you may want to consider these two things.
But also, unless they really are ornery, which sometimes unfortunately they are, attempt to make believe they're your buddy, and like I say, be Machiavellian, which means to fluff them up, say, I know this is hard work, you're always getting called by people who are mad, I'm hoping you'll be able to help me, I'll appreciate it, blah, blah, blah. Offer to send them a bouquet of roses, but but actually have that in your mind in a certain way so that they get that you want to conspire with them and that they're going to be your partner. If you could do that, that's psychologically not easy, but if you can do that, it gives you a greater chance to get help.
Yes, and putting the time you're talking to them, when they put you on hold, I have a limit, half an hour on hold. I'll have a book with me or something, So when I call back and I say, well, when I talked to Mary, she put me on hold for 23 minutes. Again, all those are indication that they're not just dealing with somebody who's going to go away. Thank you.
Just as a curiosity, so you won't think it's you against us, the doctors, let's say. Let me explain what actually happens to us. As some of you may know, you probably have no reason to know this, Medicare intermediary changed. The company that now we send our bills to is called Palmetto in California. They're actually in Georgia. So as of the 1st of October, I believe, was switched to Palmetto. My office was lucky. I was away on vacation, so my office manager had some extra time, though not the inclination to be patient. It took her 3 hours on hold to get through to somebody and to actually get it squared away so we could actually start sending our bills in. I had colleagues who may still not be on Palmetto, so because they are so backlogged with the change. So it isn't really just you folks having this problem, we are too. So to some degree, we should act conspiratorial, like we're not against you, we're in it together. If you could make us your partners, just like we want to make you our partners, that again, from a Machiavellian point of view, will work better.
Thank you. I don't know quite how to frame this, but it seems that we have in the United States a different view on placebo studies than Europe does. And I haven't participated in one because it seems to me over and over again we give a group of people sugar pills, we watch the inevitable outcome. It's the same as the last group we gave sugar pills. It's going to be the same as the next group we get sugar pills. And we have this long line, 50%, of people who have gotten no treatment on sugar pills. Why don't we just take one group, give them sugar pills, and then let everybody video them, and we'll just do that video over and over again.
So
we know the outcome.
I won't claim to actually be able to give you all the answers. I can only give you a little bit. At meetings I've gone to, that need to do a placebo arm has been decried, and to some degree it's an FDA requirement. Most folks think that the ideal thing is to do standard therapy against the next therapy, so that at least you're getting some therapy. But so you understand why the placebo idea is there at all. It isn't necessarily true that with every drug that's researched that the placebo group has the same exact response in each circumstance. So as an example, when we use certain drugs, the placebo arm is almost as good. The only question is for the FDA, is can you show that it's statistically significant difference for the drug versus the placebo? In some drugs, the placebo is as good as the drug. So placebos are actually an interesting drug. You understand that placebos are really drugs. Why are placebos drugs? Anybody want to tell me why a placebo is a drug? And is there something wrong with psychology as a way of treating? I don't think so. Does anybody think that psychology is wrong? Let me ask and answer. When you go to your doctor, some of you, by style, don't like all the extras. You just, slam, bam, thank you, ma'am, may appeal. Some people actually don't want to get bothered with all that stuff. But for many people, I think the office visit, the medical care, has to have some magic in it. It used to be that was an acknowledged element of medical care. Primary care doctors, the old family doctors that used to come to the house, even a few years ago, so I was told by family docs and even obstetricians, they would go to their annual meeting, and at the end of the meeting they would have some significant session about how to communicate, how to rapport, and so forth. It was a big part, it used to be a big part of medical care. Some people would say the reason we don't need it anymore is we got all these fantastic treatments, but it's not really true in everything. I think it's a missing piece right now, but nobody pays for it. And that which you don't pay for is hard to come up with. It's not provided if you don't pay for it. The insurance companies certainly don't pay for it, and we don't have a way to value it. So in a way, placebo is kind of, in a certain way, is kind of like that extra element. Now, the danger with placebo studies is if the person running the study doesn't stay neutral. That's an important part of placebo studies, because the person who administers the study can influence your response. We can, in whatever we do, whatever we say, could maybe make the placebo work better than it might otherwise, or the drug work better. Certainly that's true when we have comparative drug trials. I mean, I spend a lot of time with the drug reps, and they have to present me their research studies. Some of them are terrible studies, because it's quite clear that they weren't really placebo-controlled, so you don't know. So I would say that's a two-edged sword. A problem with prostate cancer is that not enough men to do studies, so doing placebo studies in a certain way wastes the opportunity. But if we had enough men to do studies on, placebo studies would be of some value in some of the cases.
The difficulty with the placebo issue is you're crafting a statistical database. Go ahead. I think I can speak loud enough. The statistics are great, but I'm an individual. I would no more participate in a study where I'm betting my life on a sugar pill. It just doesn't make sense.
Okay, so let me give you an example why, in a certain way, that could be a reasonable approach and why it may not be. There is a study ongoing currently on radiation of prostate. And yet another study where they're trying to determine if repeating a study that's been already done to see if it holds up, in which prostates are either limited radiation or whole pelvis radiation, and some patients get hormones and some patients don't. You would think that that's already been discerned, but it's not thought to be discerned. So this is actually a national protocol. So the patients who don't get hormones feel like they're being denied. And in general, up until recent years, hormones was a standard part of many therapies. But in recent years, how many people realize that hormone therapy are two-edged swords? Some of you, many of you realize it. So there's actually, it's kind of like there was a movement to give lots of hormones. Currently, it's not that we don't think hormones are good, but there's a movement against the giving of hormone therapy. So it's because it's a harm. So unless you do a study where some people get the hormones, some people don't, how will we ever prove? So not giving is like giving a placebo, right?
But in that case, there you have two comparatively, potentially effective regimens being compared. That to me, the extremes of the placebo study, though, is like a drug study where someone truly is getting sugar pills. Now, that outcome is quite predictable. And I know it's nice to have it in the statistical study, but that person's life just went down the tubes. And I just can't understand the morality of doing that.
Well,
My boss is going to give
Kim.
you the right answer.
I'm the boss. No, I guess. Just kidding. We have that dilemma a lot of times. Patients come to us and talk about placebo-controlled trials and so forth. And I can appreciate the concern. From the clinician standpoint, we would not do anything that would be a detriment to you. So if we would put you on a clinical trial and things potentially got worse, let's say knock on wood that would ever happen, but they got worse, you would then be off clinical trial. You would receive whatever therapy is appropriate. There would be no clinician who is ethical that would allow for something like that to happen, that you would get really, really sick and your disease would go out of control and we would continue on something that wasn't working for you. Our cancer research manager, who's phenomenally brilliant, she's been in front of the FDA, she's amazing when it comes to clinical trials. She went to a national conference recently, and they really educated them on how to talk to patients. And some of the things she came back with and shared with me were just really powerful. And it's in the way we talk to patients as clinicians in order to educate them on clinical trials, because a lot of people say, well, I feel like a guinea pig. And that's so far from what we want people to think. The way we look at what is in existence off clinical trials, what we call the standard of care. And what research is trying to prove is what is that latest and greatest, what is the next treatment that's soon to someday be the standard of care. So if you look at a clinical trial, you can say you've got one arm that's the standard of care, and the other arm is the next best treatment. So that's what we're studying. We're studying what is the current clinical practice and how can we make it better. The standard of care, right. So, and what's today's standard of care and what's today's clinical trial could be, the standard of care could be the old way of doing things. I mean, with prostate cancer now we're looking at abiraterone. Maybe in a year or 2 or 3, abiraterone may be a standard of care. But we need people to be on clinical trials in order to prove its efficacy. So, I mean, you look at children. I think 100% of children are on clinical trials. And look what we've done for the treatment of leukemia in kids. It's practically, I mean, it's so curable. And what is the population, the adult population? I think it's 3 or 4% of adults are on clinical trials. We got to keep moving on and find out what's the next best drug out there. So.
In this context, I understand in Europe, many of their studies are rejected by the FDA because they did not have the placebo arm, and placebos are less frequently used there. Also, terminal patients can readily get experimental drugs there, where here they're still obstructed generally by the FDA process. Would you make any comments on whether you think we would move to a more European approach, maybe being less demanding on placebo for using placebo perhaps less, doing more comparative studies?
So first of all, keep in mind I'm not really an expert on clinical studies. And in prostate cancer, we're really not doing placebos. The big problem that we're having with the FDA is what are the hallmarks to determine a response. Some people have wanted to use PSA doubling time, and the FDA has pretty much required to show survival. Problem with survival studies is that unless it's very, very high-grade prostate cancer, hopefully many of you have lower grade, slower growing cancers. Those kinds of studies would take 5, 10, potentially 15 years if it was determined by death. So there has been a problem convincing the FDA to use an alternative marker for successful use of a new drug. I don't have enough knowledge to argue further in it. It's obvious that prostate cancer, because we don't have a lot of knowledge, has many states, many different states. If we put you in a certain protocol and we try to make each same, there are different states. So it's like Chinese food. We can pick one piece of your cancer fits in this criteria, one in that, and we're supposed to take the same old to compare. But there's so many states that it's almost impossible to actually do a good study for every category. So that's another issue. Not only is it hard to get men to participate in studies, but we can't do a study on everything. So some drugs will get used out of protocol. Once they're approved, doctors are allowed to use them out of protocols. We won't actually know everything about everything. Some of it will be clinical practice experiences. But I can't speak in greater details. I just don't know.
Since I'm holding the mic, I'll try first with some more mundane questions. You've gone to the doctor, patient's gone to the doctor, and received an opinion, and says then to the doctor, I'd like to get a second opinion, and it's instantly rebuffed. Won't you trust me? If you can't, if you don't trust me far enough, you need to go somewhere else. How do you respond to?
I think you have to make a decision. It's really a critical decision. Let me explain. If you needed something done that was a rare commodity type of something, and there's only one person in the world who can do it, and he's a horse's tail, and if you don't get on with him, you're not going to get it done. You probably have to bite your tongue You can still try to work with him and be Machiavellian. But there's not a lot of services that a prostate cancer patient really needs in general where there's only one person who can do it. So while I don't recommend you immediately jump up and run out, I think you could still try. You could say something like, you've got to fluff him first. Everybody tells me you're the best. I've read your credentials, you're well trained. I really want you to do it, but it's my problem, not yours. My mother said I was always asking too many questions. I just have this need, then I'll be satisfied. I'll be a better patient. I'll recover better. You'll be able to deal with me easier. I won't be a pain in the ass. Whatever you want to say. You can try that. But if the guy stands up, because some people actually, they may have actually sat down for a few minutes to talk to you. They may actually have been too busy to sit down. If they didn't actually sit down to talk to you, I think you probably, the only thing you could do would be to say, I have a lot of questions. Could you stay a while? And if they say, I'm really busy, you might want to leave, unless they're the only one. But let's say they sat down. You go through your spiel. You try to play them Machiavellian. And they do what many people who have that personality do. They stand up, and they move back, right? And they get a stern look on their face. You probably aren't going to work through them. So you have to decide, have your friends told you enough that you're willing to put up with their personality, and
Because they have good hands.
they've got good hands. So, and you'll find another doctor. You'll come see me because I'll talk to you nice, but I don't do the surgery, let's say. So, I mean, you don't have to have everything with one person. But that's the only thing I can suggest. If you can possibly get someone else who you feel more comfortable with, who's equally good, you should. After all, unless you have managed care, which gives you relatively few options, you really have a commodity called insurance or money or whatever. That's how well we work to pay our bills and send our wives to the beauty shop. So we're supposed to be motivated. You just have to figure out how to motivate us. Bring in something. Bring us a cake. I know it sounds silly, but let me tell you, I have occasional patients who do this. I remember a Medi-Cal lady, a Hispanic lady. I didn't make any money on her. But after every visit, she was so pleased and pleasant. I couldn't stop her. She wanted to clean the exam room. I tried to stop her. She wouldn't. We would have done anything for her. So it's not exactly all about money. You're under stress. We're under stress. It's not just us, like I was saying, it's not just us that have to figure out how to work with you. Play us a little. Some of us come easier.
As a corollary to that, we're advised, and have been in the past,
Yeah.
think about the day before or the week before what you want to ask your doctor. Write it down, and you've got a prepared set of questions that you'll go home with answers to, and then you get about a third of the way through, and he says, well, I got another patient.
I got an answer for you on that one. I have patients that come in with that, and what I've learned to do now is to ask the patient to let me have the question list. Because what happened, we can learn. So for example, if I didn't know how to do that, now that I'm saying it to you, so you've heard me say it, so try it. Next time, make your list, have 2 copies. Make 2 copies. Say, I know your time is busy, doctor. I don't want to waste your time. So I made a list so I can get right to the point and you can get done and you can get on with your patient. So let me give you the list, and could you spend some time? I appreciate it. And if you don't have enough time to go through it all, I'll make another appointment. It'll cost me $10 or $15 for another copay, but I know your time is busy, doc. You say all those things to them, some of them will be embarrassed to get up. And the ones that aren't, then come back. But I think a list is great, but give it to them. Make a copy for yourself.
Do that. Going back to something you said earlier in advice, you take the logic, you try to explain and show the no right answers. There are some of us I met who say, look, I never went to medical school. I don't understand all this language. Would you just tell me what to do, please? Can you do that?
I go crazy. I really get frustrated. I forget my name. When people do that, I have to confess, it puts me off my game. I'm better at it now. But I'm so used to dealing with engineers and folks who ask questions that when I have somebody that really wants me to tell them what to do, I now know what to do when they do that. But I didn't used to, because I tried so hard to develop a whole, educational process. So that's why there's different styles. So if somebody came to me and said that, and occasional persons do, I say, okay, so what you're saying is you want me to make decisions for you. So I'll make decisions for you where I can, and there are places I can't. And I'll tell you who you might go see to get another opinion. But if you have a doctor whose style doesn't work with you, eventually, if you can't change him and you can't change yourself, you have to move on, because this is this, as Dr. Strum says, right? This is not incident. This is a life. Prostate cancer is a life. You're going to be in this business of prostate cancer for a very long time. You have to have people you can work with. He has a different, nicer way of saying it. I can't remember the exact way he says it, but basically, it's a. What does he say? It's a way of life rather than a disease. So you have to have somebody to work with.
Related to that, in the same vein, you've been working with a doctor, you're satisfied with it, part of your life, and there you are in P2P, and Strum has come up with some new research. You follow the article, download it somewhere, bring it to the doctor, and says, oh, that's those off-the-wall guys. I don't believe in it.
Okay, so that's a really good question. So let's see. I really love Dr. Strum dearly. I think he's done an incredible amount of very valuable work to bring the prostate cancer world closer to a model of logic. But I would say to you that none of us is right in every regard. So, for example, you guys have heard Dr. Strum. You've also heard Dr. Mark Moyad, right?
Right.
And do they agree on everything?
No.
So, Dr. Strum is an incredible advocate for an approach that I recommend everybody follow in terms of the style, the knowledge, the self-awareness, the taking part, the advocacy. It doesn't necessarily mean that everything he says is gospel. Now, it turns out that a lot of things he says turn into gospel. Like, as some of you may know, he was way ahead of time on the osteoporosis story. Only because of him, because I opened my mind to his stuff, I started treating osteoporosis. Osteoporosis. Is this not working?
It's working.
Osteoporosis, softening of the bones. So many years ago, he started preaching about men having osteoporosis. It was way before it was getting accepted. I was the first in my block, I would say, because of Dr. Strum, to start treating for osteoporosis. Now it's become established. So in some areas, he's ahead of his time. It still doesn't mean that in everything he'll be right. Like, for example, he has preached high-dose selenium. I don't know if he still is preaching high-dose selenium, but that, in some ways, has fallen out of favor. Or boron. I don't know about the boron, but like high-dose vitamin E has fallen out of favor.
My question is more generic. Somewhere,
Yeah.
a star, Florida, Pennsylvania, wherever, they've done some research. It's new, hasn't yet been replicated, but really resonates with what you think, and you present it to your doctor who poo-poos it.
Okay.
Isn't interested in reading it.
Excellent. So, again, there's two answers. First off, unless you can change his style in some way, non-confrontational, say, I hate to pester you with this stuff. I'm reading a lot. If you have a big interest in prostate cancer, I'd love to send it to you, email it to you, bring it to you, whatever. And if you're interested to look at it, you can tell me what you think. And if you're not, I certainly don't want to mean to bother you. Now, if he's totally against learning anything and you're doing a lot of research, he's not going to work with you for the long run. So that's number one. But the second answer is you should know that clinical research requires that any new discovery be duplicated. You probably won't be surprised to know that many things have been promised as great. They actually get in the Wall Street Journal and the LA Times. And then a year or two later, there's nowhere to be seen. So the notion that a new article, whether Dr. Strum finds it or I find it or anyone finds it, that it would be gospel, it ain't true. It has to be verified. But the stylish style part, that's important. I think you have to pay attention to our style and see if it fits with your style.
Quick question on
Yes, sir.
back on the insurance. My urologist has opted out of participating with the insurance company. What effect does that have?
Oh, good question. What it means, well, let me answer your question and then I'll go backwards from that. So what that means to you is that, aren't you on Medicare? Okay, so if you're on Medicare, your opting out would more likely be opting out of your secondary, right? Okay. You mean he opted out of Medicare? Okay, well, probably not your urologist. There are very few urologists that can afford to get out of Medicare. We would if we were incredibly famous, maybe. Like Dr. Allering doesn't take anybody's insurance for radicals, so everybody has to pay. Now, Medicare has some controls about how much above Medicare you can charge. So in your case, for example, he is a Medicare participant, so he charges you $1 million for an office visit, and Medicare says, that's funny. You're only worth $60. So he has to write it off. It really looks terrible on his book, so he won't do that for long. And Medicare will pay 80%, so they'll pay $48. Now, since you no longer have a secondary he takes, you'll have to pay the $12, and if he's a nice guy, he'll still do your insurance for you. So you'll at least get it back. But what he is saying to you, he's no longer going to take whatever your secondary. Now, why would anybody do that? Theoretically, at least, it used to be that a secondary was obliged to pay the 20%. A number of years ago, Blue Cross, for a while, stopped paying the 20% with the explanation that Medicare was already paying more than they allow, so they didn't owe anymore. They got in trouble. They got slapped, so Blue Cross became a better actor, and that's no longer a problem with Blue Cross. Sometimes United Health doesn't want to pay all of the secondary. So theoretically, at least, they have to. So if I have a Medicare contract and you're obliged through your insurance to get me the other 20% and say United gives me 10% of it, well, I'm going to ask you to pay the other 10%. But if I don't participate in your secondary, like I am not a United Health provider, so if they decide I'm not worth the other 20%, you still have to pay. That's what that means. That's what that means.
I'm trying to not get too much involved in exact details, but could you touch upon when results are sent out for analysis and they're not the same as the first analysis, how you would handle that situation?
You must be, I suspect you're talking about like the biopsy.
Yes.
Okay, let's see. Number one, the literature says, because studies have been done, that there's a significant disparity depending on certain details. So like, for example, if I do 12, 14, 16, 18 core biopsy, in other words, a big biopsy protocol, and I have a good pathologist locally look at it, versus if I did an 8-core biopsy, and I have a local pathologist looking at it, and you have your prostate out. I'm going to come to your answer. This is not an exact answer yet. And you have your prostate out. Now the question is, what's the concordance between the biopsy and the pathology from your radical prostatectomy? So the more specimens that are taken, the better the concordance. So that's one thing. If on your biopsy you have higher grade cancer, so not 6, maybe not even 7, 8, 9, let's say, there's a better concordance with a potential not to be upgraded, but actually to have somewhat a lower grade. On the other hand, if we have a 6, there's a significant potential, depending on the number of cores obtained, that your radical might show 7 or 8. So that's not your answer, what you're looking for, because you're asking, so the local pathologist looks at it and now it's sent to Boswick or to Johns Hopkins or wherever, and they come up with a different answer. So first off, let's get to brass tacks. Boswick's got a pretty good sized lab. He doesn't actually, I don't think he looks at everybody's pathology. I probably at Johns Hopkins, the fellow doesn't look at everybody's pathology. It's actually could be fellows or whatever. I don't know. Actually, our pathologists ask that question. They wonder who actually looks at your pathology. Certainly when you send it to places like Dianon, I've talked to people who have worked at Dianon or some of the other labs. They have a table with 40 pathologists. They're all hooked together, they say, by electronics. So this pathologist who has to produce, I've been told this is how they do it. He says, well, I can tell everybody around me the pod, turn it on to station 4, so he says, well, then 10 people can look at it, so I can get a second opinion right away. That's what they say. But you know, they're on a production. This is a business. Boswick's a business. They're all relatively businessmen. I mean, they're actually experts who are making money, believe it or not, even in academics. So the question is it really a better result than what you got locally? So now you have to figure out how good is the local group. So I can speak for St. Joe's. I can only speak for St. Joe's. We have a group, there's at least 4 of the pathologists at St. Joe's who had special training in prostate biopsy, and they've been doing it for years. So I, a number of years ago, stopped sending it to anywhere else, and we're doing it locally. However, if they have a question, they send it to Johns Hopkins, or if a patient says we'd like it sent out, we'll send it out. And sometimes it comes back different. Does it necessarily mean that we're wrong and they're right? I don't know. It's a good question. Now, since I told you I was strummed, I have to be honest and tell you that I know what Dr. Strum's opinion is. So we're not on Strum's panel of experts. I mean, that's the truth. He likes me as a person. He'll tell you to come see me. But I'm not on his, and Mark Schultz sends patients to me all the time, and I send patients to him. And I'm not on his list. St. Joe's isn't on the list. So you have to understand that what Dr. Strum and Dr. Schultz have done is, from their experience, they've determined who they think are the best, and they will want you to get it reviewed at the best. It ain't necessarily so that it's always going to be right, but I don't know that we have a test done the other way. I don't know if anybody's taken Johns Hopkins results and maybe send it to Boswick and see if Boswick agrees. But I do know that when they do about every 5 years, a panel of experts from around the world come together and they are attempting to update Gleason scoring. They have what they call unknowns, and they hand it out to everybody, and they see what the concordance is. So these are people that are Boswicks and other experts, and they still don't agree. So if the experts around the world who each look at it can't agree, there has to be a little fuzziness in it. That's not an exact answer, but I hope it helps a little.
The question that I asked you at that time was St. Joseph's developing a team approach to prostate cancer treatment? Now, there's some background. We talked to Dr. Schultz. One of their big thing is that they are able to manage the disease. But you at St. Joe have tremendous resources. You've got all kinds of doctors, you've got all kinds of equipment, but I wonder, have you developed a team? When I asked you the question before, you said, yeah, boy, you've asked the right question. Have you developed a team approach to that with psychologists, doctors, nutritionists, that all work in a team approach to the patient?
I thank you for asking that question again, because the blunt answer is we're not there yet. But the more complete answer is that it's a determination, not just me, but our new medical cancer center director, who's just come from City of Hope, that's where we will go. So we have it in parts. So what are the parts that we have and what are the parts we don't have? Well, first off, I should back up and tell you that there are actually very few hospitals around the country that have managed to actually develop a completely integrated team approach. Such a team, at least in theory, would be, as an example, you're newly diagnosed with prostate cancer, you would come for a visit, perhaps be evaluated and by a radiation therapist, a surgeon, an oncologist, maybe a radiologist. You would see everybody all in one visit, and we would go and talk amongst ourselves, and then one or the other of us would come and tell you what we think. There are a small number of hospitals around academic hospitals around the country that have managed to get that part of the team. And that part of the team is still not the whole team, because that's not the psychologist, that's not the nutritionist, that's not the physical therapist. So what parts of such a thing do we have? So what we have actually, other than Kim, who has a vast background in patient cancer management, and we have psychologists that have come and talked to us at meetings. We don't yet have a psychologist that's intimate in the cancer center who sees every patient every time. We have an alternative to that. We have not a caseworker, a social worker who's actually in the hospital, in the cancer center, who actually is available to see all patients with cancer. We have programs for cancer survivors, so we have a variety of programs. We have physical medicine, so we have, so example, in prostate cancer, we want to have patients start with sphincter exercises before surgery and then come back afterwards. We don't yet have a dedicated nutritionist who just does for prostate. And we don't have a medical oncologist who is strictly committed just to prostate. We certainly don't have a urologist who does nothing but prostate. So I won't say to you that we're there. I would say to you that our attempts, now we have meetings where all the disciplines come and review cases. So in certain ways we're acting as a team, but we're not there yet. But that's not where we're going to wind up. The team approach is considered the best. Many people say that. Patients want it. There are pieces of that need to be figured out. We now have a major cancer center facility, so we have the facilities where that could happen. As I mentioned, the oncologists will all be right next door. All the major oncologists that work at St. Joe's, pretty much except for two, will actually be all in a same structure right next to where chemotherapy is given. So we're getting the pieces together. We're not there yet, but there are very few places in the country that have actually, in their academic centers, who have managed to actually get it 100%. But that's what we need. Keep asking me.
You have another question?
You know what, maybe what I can do is I would take suggestions maybe afterwards when I go outside,
Okay.
if you can.
Yeah, because we have a few gentlemen here, and I wanted to follow up on the biopsy business.
Yeah.
I, as many of the people that I know in this group, have had their original slides sent to a Bostwick, to an Oppenheimer, and most have gotten different results. Usually it's an upgrade. In my case, I was lucky Bostwick downgraded me, okay, from a 7 to a 6. Do I think the first set of results I got from the local lab is definitive? No. Do I think Bostwick's is definitive? No. But it all adds up at the end of the day with the stromology that I'm into, that it's a snapshot of where you are to give you the most information that you can achieve at any one point in time, so you can try to make the right decision. It's a puzzle that kind of fits together.
Now the grump I have is, at this point in time, the general overall practice of prostate cancer therapy is not discriminating. Even though you have your biopsy done here and it's reviewed there, and as we talked at dinner, right now there is a significant movement in the last few years to operate on everybody. I can't tell you it's correct. but major medical centers have supported that. So that's the current notion. So unfortunately, and that's why I say the future has to bring this. Better diagnosis, better visualization, better markers so we can decide who should get what. So not everybody gets their breast off or their prostate off. So breasts already have some discrimination. Prostates at this point don't exactly have that.
Wouldn't you agree that most urologists will look at maybe three things, PSA, Gleason, and what they see on an ultrasound?
They look at it, but they still cut it out.
But wouldn't you say that there's a number of other things that can audit those three?
Well,
Repeat the question.
I think that you are just saying the other side of the coin of what I'm saying, which is that we don't have a refined way of providing you folks with customized, directed therapy based on best evidence to give you the least side effects and the best outcomes. At this point, we're using expensive robotic instruments, so that sounds like a refined, delicate instrument that's supposed to be special, but it's doing the same exact thing we did with an open, which is a hammer. We don't yet have what I would call a scalpel in concept to manage folks in a particular manner suitable for each person separate. The testings, the studies, all these things I mentioned, they're all coming. Vast amounts of work being done. The amount of literature. I have news clipping services that I read every day, and they, from all over the world, they're researching this because this is a big problem. If you look for it, you find prostate cancers. So there's a lot of work to do, but we're not there yet.
Yeah, one of our past speakers made an analogy that I've always liked. He says it's often akin to carpet bombing a state to kill a village. And so that's kind of what stuck with me.
I would say that's a reasonable analogy. Yes, sir.
I worked in engineering, and I see different characteristics in different engineers, all of them being very good. Some are very good at marketing their knowledge, and others are very good at withholding their knowledge, yet they're still very good engineers, and I'm sure this happens in the doctors too. We tend to go to the ones that you hear about, which are the ones that are marketing. Is there any other way of doing this process of selecting a doctor?
You know, that's a really good question. I got to focus out before I focus in. A number of years ago, 20, 25 years ago, I got asked to take part at the Orange County Medical Association in some form. And I told the fellow who was going to be chief OCMA president that year, I said, I don't want to do what you guys want me to do. I want to do what I'm interested in. He said, what are you interested in? I said, communications. So I got to run a communications task force. During that, I got to have all kinds of marketing people come talk to us. And I had a change of heart about marketing, by the way. So I used to look down on marketing. I used to think marketing is what less good people do to sell an inferior product, whereas if you're good, I'm good, so you guys know I'm good, I don't have to market. So that was my attitude. And I got disabused of that attitude, and here's the reason why. Why not think that there is bad marketing, but what if you never have good marketing? What if I'm actually good and I don't market and you don't get to know about me? So I think actually marketing is potentially good. So if we market, then you have to figure out how to judge us. That's an interesting topic. So focusing in, how to find out about doctors who don't market is what you're saying. So one of the ways, of course, is to talk to friends. Is that always a good way? Well, I mean, it depends. If you have a bunch of friends who've had radical prostatectomies and several of them say they got out of the hospital in a day, they're continent, they're potent, So does that mean you won't be the one that falls out? No, but I mean, it gives you a sense of confidence. What if you go to a professor? You're probably not going to be able to, are you going to get honest or dishonest information? Who knows? I mean, you don't know. Is there such a thing as dishonest information from medical centers or professors? Anybody thinks there isn't? So, but a lot of us in private practice don't have data. That's a big dilemma. We don't have data. I can't tell you in a convincing manner the results at St. Joe's. Why? Because up until now, we haven't had a system for data collection. I've been the program chairman for 5 years. On my original game plan was data. The cancer center administrator has run 2 previous cancer centers. She's well aware that data is needed. Our new medical director has, as I say, been running parts of City of Hope, data, but we don't yet have it. We're in the process. When we spend some bunches of millions of dollars, we're going to have a computer system, we're going to have data system, we're going to have data. Data is very much valuable, so everybody wants data. So now we give you data, it looks like my slides. It's pretty, or not, but at least it's black and white and you can project it. So now you have data, so now you think, okay, he's got data, so now I know what he can say. The other person doesn't have data. So does that mean that because we've done a fancy job of putting the data together that we're necessarily better? Well, that's an interesting question. So there is some information that's been in the literature. So I'll give you some information. So for example, Sloan Kettering has published data about how many radical prostatectomies your surgeon should do and how many the hospital should do. So low volume versus medium or high volume. So it looks in general like a higher volume hospital, it does better in a variety of ways. But then if you read more carefully, they actually broke down the surgeons who were in the high volume. And some of the high volume surgeons had really good data and some didn't. So the same high volume hospital with good data, it still doesn't tell you exactly. So I don't exactly have a right answer for you. It's a dilemma. It's a big dilemma because you're going to put your hand, think about it. You got, I mean, maybe not for a radical because I'm doing it anymore, but somebody comes to my office and the next time they see me, I'm doing a vasectomy or whatever. You know, they don't know me. They just know my personality. I tell them whatever I tell them. I have to stand for something and they get it. Is that a valuable thing? Well, I think unless you're having some critical thing like a prostatectomy or your open heart where you need to do more research, that seems to work out in most cases, but it's a dilemma. I don't know how to tell you. I really don't. It's a dilemma. I don't have the answer to solve your question.
This question may not be in your category. It seems like they're collecting a lot of biopsies, you know, everyone that looks like they're positive on a PSA, and they're getting Gleason scores and that. Is there anything beyond that that they're learning from this for, say, like DNA or chemical analysis of that?
That's excellent because, as I was pointing out, that's an area of need. So there are a lot of places that are really doing that. They are doing it in a research mode with high technology. They're able to take tissue, and they're able to take a computer chip actually, and prepare antibodies to antigens. They can have computer chips with 640 or 1280 or 4,000 antigens. And they have to, I'm not a researcher, so I can't tell you exactly how they do it, but they're able to take fluids or tissues and do an antigen-antibody response and see what's present. And using data like that, they're able to find that certain certain DNA changes actually are more, so then they do, actually what they do a study to see what DNA changes are present. And at that point, they don't know anything. All they know is this is what's present. Then they take patients with cancer, without, and then they do a computer match. So these patterns of DNA are more highly associated with having cancer of a higher sort. So then that develops into the ability to look for certain specific DNA changes. So what I was saying about the urine, the PCA3, is actually looking at a certain DNA change. There's another DNA change that's being recommended, and most recent articles said that what will probably happen is they'll add that in. So it'll be a combination of 2 DNA changes. So they're doing exactly that. Now, what is available currently? So there's a company called Orion that markets, they're in the East Coast. They take a slide and they do a variety of other fancy things with it. I mentioned it to my pathologist. He says that we could send our tissue there, but what he's not yet aware of is what will we do with the data. So what they're doing, we're in the early stages. We're looking for the presence of things to correlate with the presence of other things. If we find it, then has to be a study to decide what is this going to do for you. We can spend your money doing it. That's the question I'm being asked. I bring all these I read a lot on book knowledge. So I bring it to this person or that person, and they say, what are you going to do with the knowledge? We don't know yet. But that's where I think it's going to go.
I'd just like to make a comment. I'm with a major HMO. You probably would know which one it is. I just finished building a beautiful new facility, and I've had many hours of discussion on this, and their business model is probably the antithesis of what we're talking about here, but it does have some logic to it. And they point out I shouldn't confuse research activities with clinical practice. Their point is that if you don't have prostatitis, you don't have an enlarged prostate, your PSA goes up, you get a biopsy. Biopsy shows cancer, the treatments are clear. It's going to be surgery, radiation. They don't advocate drugs. So the refinements, they're in the new facility, they did not put in advanced imaging. They do not use color Doppler. They don't care because it doesn't affect the outcome. And the least cost approach is to do the biopsy, avoid training people for all these specialties that they feel are of dubious clinical significance. That is their model. I don't think it's going to change.
Well, you're talking about Kaiser. My wife actually is a nurse anesthetist. She gets to work at that brand new hospital. It hasn't gotten all the kinks out, but Kaiser is a successful model. And if you're looking at a model that might be cost efficient, they certainly have a lot of cost efficiencies, but that's not the place where the advancements are going to come from. Now, all the advancements, all these new things I've talked about, we don't, and you know, the DNA things and so forth, we don't yet know if any of them are going to help. So, for example, Kaiser doesn't do robotics. They do a lot of laser prostatectomies. They're one of the heaviest volume laser prostatectomy places in the area. City of Hope used to be big in, did I say laser? I meant laparoscopic prostatectomy. City of Hope used to be the #1 in laparoscopic. Now they're the #1 in robotic, which is a form of laparoscopic. So, I mean, Kaiser's model is based on cost efficiencies. They're very good at analyzing these things. Even so, I know enough about them to tell you, without giving secrets away, they're not the most efficient in everything. They still have lots of inefficiencies. I won't tell you about them. I mean, I don't work there, but my wife tattles. So, I mean, even their model is not what you would call totally efficient. But they're a rational system. A rational system says if it ain't going to help you, why should we do it? And that's not a bad idea, except how do you get anywhere further? So I agree with Duke Bond that color flow is great. If I had it, and I'm hoping we're going to have it, I will use it. If we can get this 3D geographic localization thing, I think it'll be spectacular. I think you all, if we get it, you all are going to want to come and have it done by us. UCI is getting one of those same units. You're going to want to have it done the best you can if you could. Now, you're not probably going to come in and say to me, you're going to use this fancy equipment, what are you going to get? What am I going to get for using the fancy equipment? You're going to say, I want a robot, I want the best technology. I have to be honest enough to think somehow in my mind it's going to be advantageous for you. Otherwise, I wouldn't do it. But you're not going to get it at Kaiser. They'll get it eventually if we can prove it. I don't think Kaiser will forever not do things. I think they're just a very they try to be cost efficient. I can't argue with it. It's not going to get us to the next level that way.
I just, signing off, I wouldn't like, Kaiser in general health care, I think is superb. But in this specialty, I think they're in the dark ages.
We're in Sunset? Okay. Yeah, Sunset is... Oh, okay. Sunset is, people who know anything about Kaiser knows, is their flagship. That's where they do the open hearts and so forth. So that makes sense. I didn't realize that they had it there yet. Yeah.
Thank you for coming here tonight, Dr. Weissman.
Thanks for inviting me.
And I really liked your comments about Dr. Strum and Dr. Schultz. They were my doctors for, for many years. And again, Dr. Schultz is my doctor. But what I wanted to talk to you about was I have some ideas on how to get the best information out of your doctor. One is I like the idea of you gather the information and keep a logbook, a 3-ring binder. All your reports go in it. Keep a log in it. And then when I suggest this to guys that have prostate cancer that I talk to, that if you want to get the most benefit of the time you have with your doctor, spend some time and write down your questions. And I encourage them to write a brief summary of where they are so the doctor doesn't have to ask them 20 questions. You know, they can quickly read through, my PSA was this much and I had to biopsy this, and et cetera, et cetera. But the one thing that I'd like to stress to people, and I want to see what you think about this, is I encourage them to take a small tape recorder with them. And some doctors are very nervous when they see tape recorders, but you can set it up by saying, you know, I know your time is valuable and I want to get all the information out of this visit, and I don't want to try to remember everything you told me. I don't want to try to take notes. I want to concentrate on asking you the questions, and then I promise that I will play this tape over and over until I really get everything out of it, even if it takes me 2 or 3 days. So I wonder what your comment was on that.
I obviously think that's spectacular, and I have to confess I've been remiss. I mentioned it to some patients, and I've not been consistent. And those who see Dr. Schultz know that he offers, I think there's some charge, but he offers to videotape his interviews so that you can play it and actually see him. I think it's spectacular. I have mentioned it to our cancer center at some point in time when we actually do have a more group practice type model, if we can get there. I will continue to mention that. I think videotaping and recording is, I think, great. Patients don't hear everything we say, even though we think, you know, I spend a lot of time talking to people. I've been disabused of the notion that I really am getting everything across. So I do something a little different. I don't have an electronic medical record system, but I'm a typist. I type a Word document and I update it and I email it to everybody. And as you may know, the federal government is making a push. Sometime in the not so far future, they're going to try to make us do all our prescribing by electronic means, and they are also going to make electronic medical records more and more necessary. They're actually loosening up some of the Stark laws, which I don't know if you guys know, but that's the laws that allow hospitals and doctors to get any benefit from each other. So like hospitals can't give me something in return for which I'm going to send all my patients there. But because the government is motivated for this electronic medical records, they're actually going to loosen the Stark laws so that hospitals can provide electronic medical records systems that we could have at minimal cost, with the idea of sharing data so that, for example, you don't have to go to 5 doctors and have a difficult time getting your data shared. Right now, it's hard to get data shared. I mean, I would say we spend a modest amount of time having either you or my office staff call to get records. So recording is only part of it. That you can record me, but how do you get the recording to be of value to the next guy? I mean, so how do you share data is really an issue. I think collecting bookfuls is good, but this is, again, style. I mean, I'm a typist. Most of my friends aren't going to do EMRs where they have to type. They're more into point and click, so there'll be multiple solutions. But somehow the data needs to be shared. And it's not just so it looks neat. I'll tell you another thing. If you have a chart that's yay thick, and it's all handwritten, which is what I used to do, and you would come in and you're a complex patient, I used to rifle back, if I had time, I'd rifle back through it to try to pick up everything from the past. Then I'd look in the labs, and so then I'd say, okay, now I know where we were, now tell me where you are, so I can make it, because that's what I'm supposed to do, right? I can't just see you now. I have to see you now as in context of where you were, so I can see how you've come there. So electronic medical records of some sort are going to improve care, because the doctor at least won't have to take a lot of time to see trend lines. He'll be able to see PSAs over time. Unless you either got to have a form or some electronic medical records. Otherwise, we're going to miss things. Because, you know, right now, the reimbursements are going down, so many doctors are taking on more and more patients, assuming they have them, to try to run more through. And that means less time to be critical in thinking. So something needs to be done. You could help. I have patients that are engineers that show me their PSA graph. It's harder for me to miss something. What if I run through it and I didn't have my own? They can say, hey, you know, excuse me, can I take another minute? See, it has jumped. Shouldn't I do something? So, I mean, you know, I agree. It's a big communication issue. Care falls down in every level, nursing care, hospital care, doctor care, insurance care, everything, when communications lag. Same thing in the hospital. Wrong-sided surgery, I mean, that's a communication problem. Communications is critical, and the government recognizes it. How they're going to solve the problem is, I already told you a couple of things. Another thing the government's doing already is certain complications that occur in the hospital, like with Medicare. The hospital can't charge them for it. So, for example, trying to remember an example. Let's say if you have a central line, a venous line, and you get an infection, you get sepsis. You might have to be in the hospital another month, expensive medications. I think that's one of the areas where the government is not going to pay the hospital to take care of you. Doesn't mean you won't get cared for. The hospital is forced to take care of you, but they have to eat it. So the motivation is, unfortunately, there has to be pressure, but when your pocketbook hurts, you do things, right? So you're going to do things, I have to do things, the hospital's going to do things. I think in the future there will be better systems. But your part I totally agree with. You only asked me a little question. You see, I took advantage of you.
Okay. All right. Well, I think there's another question, but Larry, what? Yeah. But Larry has asked me to provide you with our speaker's cup, and we want you to take that home.
I feel honored. I feel honored. And again, if you ever get a Strum medal, I'd like one.
Years ago, when somebody had cancer, and I'm not thinking of prostate cancer, it was not uncommon to talk about guided imagery. I haven't heard that in many years, and I wonder if you had any knowledge of the use of guided imagery, meaning where you try to think your way into curing the cancer, et cetera, et cetera. I wondered if any studies have been done on prostate cancer, or whether the whole concept has lost its validity in the medical field.
How much time do I have?
5.
Oh, you mean you guys going to run away if I take a few minutes to answer? Because that's not a simple question. You didn't actually, I don't think, exactly. We opened the can of worms is what I really mean. Because what you're talking about is alternative therapy. And I definitely believe in alternative therapies in a way. I don't believe it in another way. So what I actually think is a partnership, not just between patients and doctors, but between patients and doctors and the spirit, whatever that means for you, be it psychologist or the preacher or whatever, be it a faith healer or an acupuncturist, a partnership. So what I don't believe in is that guided imagery or homeopathic medicine or high colonics are going to cure prostate cancer. As a matter of fact, when I have patients that bring that up, I tell them, if you do that, you're going to be killing yourself. And if that guy does it to you, he just killed you. You just haven't fallen down yet. And I have patients who have done that. They've listened to me and several other doctors and didn't like what we said, and they went to someone in Tijuana or in San Diego that practices alternative medicine. They came back 6 months later with a cancer farther advanced, and I looked them in the eye because I don't know a nice way to say it. I have to say to them, that guy just killed you, because basically you're going to die. Maybe you would have died anyway, but you're going to die because we can't cure you anymore. So I think partnerships. So the notion that doctors know everything, clearly not right. You all know that. We don't know everything. The idea that a guided imagery knows everything or is the only approach, clearly that's not true. But I do know that there research has been done showing things like laughter therapy, a strong spiritual faith, meditation, whatever you want to call it, guided imagery. It's alternative, but none of it's bad. It's all good as partnership, not instead of. So if guided imagery works for you, you have to find somebody who does it. There are not a lot of people that do that. I don't know if it's fallen out of favor exactly. I just don't, there's no way to, well, first off, there's no way to charge for it. I don't know who you would go to get it. Doctors don't typically do it. My wife worked at Harbor City before she started working here. There was an anesthesiologist there that used to use pranic healing. A Vietnamese anesthesiologist, she thought the world of the guy. He did pranic healing. His patients were so relaxed when he put them to sleep and didn't need as much anesthesia. These things have been proven. The doubting mind is an okay place to be, but as long as it's not instead of, why not have a partnership? Now, at our cancer center, I've stood up for the idea that we should have, for example, an acupuncturist, exercise therapy. A lot of prostate cancer patients woefully need to have exercise therapy as part of their care when we give you hormone therapy, or even if we don't. If you don't lift some weights and do some regular exercise, you may outlive the cancer, but you'll get a hip fracture. And you know, older people with hip fractures have a 50% risk of mortality. So we're not taking care of the whole person if we don't do some of these other things. If you're going around depressed, you may commit suicide, or there are studies that show depressed people don't do as well with chemotherapy. So if we don't pay attention to your whole, like Dr. Strum says, the whole person. So guided imagery, I don't know if it's died out, and I don't know who does it, but it was a good idea, and I think there still is some idea behind it, but I don't know who does it. Who? Oh, yeah, but I don't have a way to send anybody to him. Yeah.
I think there's ample places people can go to find what floats their boat in that respect.
So if you guys have lists of these kinds of services that we don't have, this is another thing I'd love to have.
Yeah, we can. I can get that to you.
Maybe we'll provide it for Kim.
Yeah. Well, let's thank Dr. Weissman for his appearance and his time.